Impact on Your Health is sponsored by Dennis J. Courtney, MD, Director of the Courtney Medical Group, located at 3075 Washington Road in McMurray, Pennsylvania. For more information or to make an appointment, call 724-942-3002. That's 724-942-3002 for Dennis J. Courtney, MD.
Good morning, everybody. Good morning, everybody, and welcome to AM Impact on Your Health. AM Impact on Your Health, where every day our goal is to have you learn at least one thing to help you live better and longer. AM Impact on Your Health is heard each and every Monday, Wednesday, and Friday from 8 to 9 o'clock. I'm Dr. Dennis Courtney, and I'm with you each and every Monday, Wednesday, and Friday from 8 to 9. AM Impact on Your Health, where each day you'll find current medical news, knowledgeable guests, and fascinating health topics. And of course, where we do encourage you to call in to join in. Today, well, you're going to enjoy our guest today. You know him already. He speaks about all things colon. When he came to us with just a fantastic discussion about fiber that we never even knew we had a problem with. We thought it was wonderful stuff. We learned more than we ever thought we could learn about this issue of constipation. You can remember we did 2 shows on constipation. I can't believe that there's that much to talk about. There's still more to talk about, I'm sure. Today, in keeping with the theme of all things colon, how about this neat little procedure that's been going around for quite some time? I wonder how he, our guest today, feels about the colonoscopy. Hey, is it all trumped up of what it's supposed to be or purported to be? Or are there problems with it you need to know about it before you consent to having one? Well, our guest today should know all about all things colon, and what better representative than a colonoscopy for him to pick up where he left off. Our guest today, Konstantin Monastyrsky, the expert on all things colon. We'll be with him right after our first break. If after discussing this issue, or while we're discussing it, you want to call in to ask a question or to make a comment, that number, of course, as always, will be 412-825-6262. That's 412-825-6262. Colonoscopy today, through the eyes of Konstantin Monastyrsky, right after our first break. Okay, the month is clipping along, is it not? We're in Thanksgiving week, folks. So coming up really close to the tail end of the month. On Wednesday, we're going to have a local guest. Now, I've never met her, but she's right out there. She's in the Regency, or the Regent Square area of town. She is involved with something called Yoga on the Square. Interesting take on words. And she's going to be our expert, giving to us our introduction about yoga. Everything you ever want to know about yoga, I call it Yoga 101. She's going to be our guest on Wednesday. Joanne Spence is her name, and I'm looking forward to having a chance to talk with her. I hope you will too. On Friday, now look, Thursday's Thanksgiving Day. Friday will be a repeat show. I haven't decided which one yet, but if you have a request that you want to convey to us about a show you'd like to have repeated, why don't you give us a call and let us know what that is, or email me one way or the other. That decision is going to have to be made by Wednesday, and I'll let you know on Wednesday which one will be on the Batters Up on Deck Circle for Friday. Then next Monday, he'll be back, talking about Konstantin. He's coming back. We'll find out what's on his mind on his second address next Monday when we talk to him today. He's got a lot going on. As you could well imagine, Konstantin has not let grass go under his feet, and every time he pursues something, we get the benefit of all of his research. We've benefited so far, and right now, and so much right now. Let's see where it leads us. We'll be turning the page coming up next week and moving into the month of December. And already in December, on the 2nd, we have David Bradstein coming back. And on the 7th, we have Susan Smith-Jones. And you'll see how this thing fills up as the month goes on, that dreaded month, December. Well, is it dreaded, or is it really look forward to? I don't know how you look at it in your family. But nonetheless, it's coming. You better get ready for it either way. Now, MCG testing, folks, tomorrow. we're starting and relaunching our presence out there in the eastern part of town, the Monroeville area in specific. We're going to be returning to MedHealth Services, which is the large corporation put together by Dr. Oliver Caminas, located on Monastyrsky Boulevard. His older building now sits unoccupied, but literally across the street from it sits the new facility. Monastyrsky Boulevard in Monroeville in particular is now, at least to put it this way, we should be geographically pleasing enough now that we're coming out to the east so that you can make contact with us, schedule work with us, and consultations with us that heretofore weren't too comfortable for you. Too much distance to travel, too many holes to go through, too many rivers to cross. I understand it. Now, starting tomorrow, we do return. We're going to be there tomorrow at the offices of Dr. Caminos doing MCG testing. For those of you who have signed up and are already slotted, we'll be seeing you tomorrow at the designated time. We still have additional slots available if there's anyone out there listening today who is very close to the Monroeville area and thinks like they would like to participate in the MCG testing we're doing. Of course, MCG testing is a completely no frills, no problem, no risk associated with it way of determining the absolute status of the coronary arteries. Heretofore, only cardiac caths could do that, and these are extremely dangerous and risky, and obviously nobody is going to just sign up to get one of them done. But we have a 91% accuracy, 91% accurate way, I guess better way of saying it, of determining what the status of your coronary arteries are. How much plaque is in those arteries? Well, cath can absolutely tell you, but who wants to have one? The MCG test will lying on a bed over a 6-minute period of time. We'll do just that, and it's called MCG. It's an insurance-covered test. We're just starting to bring the two of you out in the eastern part of the city. Starting tomorrow, I'll see you there. Give us a call if you have some interest and think you can get it done in the month of November. Give us a call at 724-942-3002. Right after we go off the air today, and we should be able to get you slotted. By the way, just should mention, we'll be out there monthly, so if November doesn't work out for you, we'll have a December date, and then a January, and then a February, and it'll just go on and on like that. Additionally, HCG testing done here in our office, and new approaches to cancers are under the envelope and the rubric of something called the trophoblastic theory. And the trophoblastic theory, although it was initiated in the last century, in 1904, really, by Dr. John Beard, it is gaining prominence and a foothold in terms of how we view cancers today. They are coming from trophoblastic tissue. HCG is made. HCG is human chorionic gonadotropin by trophoblasts, and there you have it, a way that you can detect, and you can, with the lab testing we have today. Through blood testing and urine testing, a triplet of tests, 2 blood, 1 urine, you can detect a cluster of cells of cancer as little as 12, and that is just phenomenal, folks. So if you wanted to hear more about that, I urge you to go back and listen to the show we did. I'm going to give you the date. The date is the 2 dates, October 10th and October 12th. Just go onto the archives, and you'll be able to listen to our show that we did with Emil Shandling. Dr. Shandle is a director of AML, American Metabolic Laboratories, and he's the only lab in the country that actually can do the HCG testing to the level of specificity that I just described. So we are the draw station here. If you'd like to get this testing done, it does require a contact with a medical doctor who can then write your prescription. I'll be more than happy to act in that capacity for you if you think you'd like to get that testing done. So HCG testing is available here, and we'll let it go at that. All right, let's do this. I'm excited. I want to get to it, don't you? We're going to take a quick break, and on the during the break, I'll get a hold of our good friend who seemed to know everything there is to know about the colon. Well, if he does, he would know a little bit about colonoscopies, would he not? Wouldn't you like to learn that? And that's what we're going to do today with Konstantin Monastyrsky. We'll be back in a moment with him and discuss that very matter on our return.
This is Dennis J. Courtney, MD. You become confused about how best to manage your health. It's no wonder. It seems that every time you turn on the television or radio, another expert has yet another suggestion for you to follow that seems to be reasonable enough, but no matter how dutifully you follow the instruction, it just doesn't quite produce the results that you are looking for. If this confusion sounds familiar to you, give us a call at the Center for Complementary Health, where we'll make some sense of the confusion based on a blending of traditional and alternative medicine that we've been perfecting over the last 7 years. We offer metabolic nutrition testing, immune system repair, natural hormone replacement therapy, chelation therapy, cutting-edge allergy correction, and a host of other safe and effective alternative therapies.
Dennis J. Courtney, MD, is located at 3075 Washington Road in McMurray. Phone 724-942-3002.
Want to help your family eat healthier? Instead of learning to disguise tofu in wondrous ways, how about some real nutritional power? If your family has the typical American palate for fries, pizza, and burgers, giving your family the blessing of good nutrition is a struggle. Fruit of the Spirit is the answer for your family's nutritional needs. Fruit of the Spirit is an all-natural, whole fruit puree made from fresh fruits native to the Holy Land with alkalizing minerals. Fruit of the Spirit was 5 years in the formulation, the work of a team of top nutritional experts with independent science to confirm its antioxidant power. 1 ounce a day provides the equivalent of 5 servings of fruits and minerals. Fruit of the Spirit is convenient, affordable, and delicious. Even your picky family will sing the praises of Fruit of the Spirit. Give your loved ones the blessing of good nutrition. Call 1-800-442-3793 for a special promotional offer. Fruit of the Spirit, a blessing for your good health. That's 1-800-442-3793. Call them now, 1-800-442-3793.
Good morning, ladies and gentlemen. Welcome back once again to AM Impact on Your Health. Heard here on KHB 620 each and every Monday, Wednesday, and Friday from 8 to 9 o'clock. We're here today with you on a Monday morning version of the show, and with us is an old friend. I always enjoy the opportunity to say that, but in this particular case, I really do mean it. Become a very good friend of ours. So knowledgeable he is on the GI system in general, but specifically issues dealing with the colon. We learned so much about him through his work entitled Fiber, and we discussed that at great length. We had really quite a go-around on the issue of constipation, which I didn't think that much could be said about that subject. Boy, little did we know. And now today, something that I think all of us are going to confront at some point in our lives with respect to sophisticated testing involving the colon, referred to as colonoscopy. Let's say good morning, however, to our good friend, welcoming him back, and say, Konstantin, thanks for coming back again. Enjoy having you with us today.
Good morning, Dr. Courtney, and good morning to everybody in Pittsburgh. Thank you for inviting me.
Well, the invitation is always an open one, Konstantin, and of course, a little unknown to our listeners is that you and I keep communicating by email, and we've been doing this for quite some time now. And I got to say, Konstantin, you are heavily engaged in one project after another. Could you, just to let our listeners know, what have you been doing since we last spoke with you? What's the projects that you've completed? What are the projects that you're going to be taking on? Because from our email communications, it seems like it's just that never ends. One project swings into another and another and another. So give us a quick update on what Konstantin is doing.
Well, thank you. Since our last conversation, I went to Florida for a month for a sabbatical. Spent the whole month under the sun. Florida is just absolutely great. It's like a paradise. And I really needed this time out so I can concentrate my thoughts on actually what project is worth working on. And I decided to write a book entitled Performance Nutrition, The Art of Eating Without Harm. And it is an absolutely fascinating project because, I write a lot about nutrition and people always ask me, but tell me what to eat. And I say, well, my work is not about what to eat. My work is about what not to eat. And so this book will be completely dedicated to the subject of what not to eat because, as you know, in our country, the dominant concept of healthy nutrition is concentrating over healthy food. And since you can, a lot of people thinking, well, you cannot have so much of a healthy food. The more you eat, the more healthy you become. Actually, it is the complete opposite. And so that's what I'm working on right now.
When do you think that just sounds like a fascinating way to look at the issue of nutrition. When do you think that baby's going to be released?
I'm hoping to get it done by April. And
that's right around the corner. All right.
Yeah, it's very close. The book is more or less written because I did a series of lectures on that subject. So the lectures are the core of the book. So essentially what I have to do is now taking my lectures and rewrite them into the book. It's not a very complicated process, and I'm fairly prolific writing-wise.
Well, let's say we'll be awaiting that anxiously. I enjoy having you coming back. We're going to be talking to you like 2 weeks in a row, today and next Monday. Today is an interesting topic that I'll come back to in just a moment, but already for next Monday, could you let our listeners know what our subject's going to be about then? Because I think we can titillate them a bit to make sure they're here 1 week from today.
Thanks a lot. Well, I did a tremendous amount of work researching everything related to diabetes and weight loss, and the issue of diabetes became a subject of my second Russian language book, specifically dedicated to the issue of diabetes, including juvenile diabetes. And I'm doing that research since 1996. I wish to remind to everybody that I am a trained pharmacist. I graduated from a medical school in Russia many, many years ago. Unfortunately, or fortunately for me, I didn't like that specific career path, and I became a technologist and spent a lot of years in high technology, working with such luminaries as even Bill Gates. I was actually, I don't know if you know this anecdote, but when Windows 3.0 was introduced, I was the only programmer actually invited to this introduction, and I was on stage with Bill Gates. He personally invited me. I was so good at programming. And so it led to a very prolific career in high technology, and unfortunately, that career terminated in 1996 because I myself was affected by very severe type 2 diabetes. And it's very difficult to people in high-tech industry because it's a very stress-prone occupation. You spend tremendous amount of working, and you compensating this with overeating, and also you kind of like, you try to look at leaders like Steve Jobs, and they're all vegetarians because they want to live forever and to be very healthy. And unfortunately, vegetarian lifestyle is completely incompatible with that specific occupation because if you are vegetarian, you're over-consuming carbohydrates. With a human needs of about 200 grams a day, you're consuming about 400 to 500 grams of carbohydrates a day. And I ended up with a very late-stage type 2 diabetes. I looked good because I was still young. I was only 40. And I went to a lot of physicians, and physicians were using an old, outdated test, fasting blood glucose. Unfortunately, it is not a very precise one for young people, and so my diabetes was missed. And this led to the closure of my business because I wasn't able to function. I barely walked. I had very severe carpal tunnel syndrome. I couldn't sleep. I became almost an alcoholic because of sleep problems. I needed a lot of alcohol to actually kind of put myself to sleep, not in the literal sense of the word. And I also became very enraged and hysterical, and I had a very hard time working with my staff because that's very typical for people with diabetes because they have a very elevated level of insulin.
Oh, and wait a minute, a mad Russian, I can't believe that. My goodness gracious. A mad Russian. What a concept.
Yeah, that was something like that. And that's how I ended up writing about the subject and researching. And 4 years later, I was fully recovered, fully functional, brought back my weight to norm. And the only thing I really did is I reduced the, it sounds very simple, but essentially I changed my diet toward a low-carbohydrate diet, and it really helped toward low-carbohydrate diet, and it helps a lot. But obviously, along the way, when you are that age and you have already so much of pre-existing damage, it's very, very difficult to transition to a different diet. It's very difficult to maintain it because it exposes you to a tremendous number of side effects, particularly related to complications with digestion, also complications that happens as an outcome of diabetes itself because it causes a lot of nerve damage along the way. I mean, it causes gastroparesis, delayed stomach emptying, it causes severe enteritis, it causes constipation, and everything in between. So that's what we're going to talk about during
next week. There's quite a build up there. I'm glad you spoke, and I hope our listeners tune in 1 week from now to get that link that you were able to establish between diet and diabetes and carbohydrates and the like. Today, which I thought was interesting when you brought this to my attention, I didn't realize that you had an opinion on it. I should know better. You have an opinion on everything, Konstantin, so it shouldn't be a surprise that in your area where you have a lot of expertise that you would shed some light on something that the American public has been exposed to for a number of years, that I think it's safe to say that every single one of us at some point in our lives is going to be confronted with an invitation by our doctors to have something called a colonoscopy. And I'm guessing, well, I know that there is an eyebrow that gets raised by the patient with that. There's just a natural tendency to want to shun it, but we're being exposed to how wonderful this was, that everyone should have one, that you should have one a year, that you should have one if you have a history of it, even more than one a year. Let's set the stage for why you became interested and now can speak so knowledgeable about the subject of the colonoscopy. Take it away.
It came by an accident. Back, as you know, I have a website entitled GutSense, GUTSense.org, and that site is specifically dedicated to colorectal disorders. And the reason why it is dedicated to colorectal disorders is because my prior work was related to damages associated with overconsumption of fiber, or specifically a processed fiber. It's very popular in the United States. Specifically, a lot of people are using laxatives, and a lot of people fiber-based laxatives such as Metamucil, and a lot of people are consuming foods that are specifically fortified with fiber, the whole wheat bread, morning cereals, and when I was working on the subject of constipation, I realized through the research that the primary cause of chronic constipation is actually overconsumption of fiber. It is not really noticeable when you start doing it when you're in your 20s or 30s or even early 40s, but by the time you reach about 50, unfortunately, colorectal organs, specifically the colon, accumulate so much damages from that excessive fiber, from straining related to large stools caused by fiber, because it's called a bulking factor. It actually, what does it bulk? It enlarges the size of your stools. And the moment the stools get enlarged, they have a very hard time to leave your colon through the anus, and you start to strain, and straining leads to hemorrhoidal disease, and it leads to diverticular disease. And fiber fermentation itself leads to inflammatory bowel disease. And a lot of people know about also IBS, irritable bowel syndrome, that affects close to 60 million Americans. And it's all related to fermentation of fiber. And then, while researching that subject, I also came across a very interesting note in the Merck Manual of Diagnosis and Therapy, which specifically said the dominant theory of colorectal cancer is excessive fermentation in the colon. And they actually didn't say excessive fermentation of what, but there is only one single substance that can actually get fermented in the colon, and that's fiber, because it's indigestible, and insoluble fiber is indigestible, and soluble fiber is indigestible in the stomach and in the small intestine, but it is being fermented in the large intestine. And when fermentation happens, for anybody who ever made beer or wine, you know what happens in the process. Lots of gases, the cause of flatulence, and lots of acidity, the cause of irritation, and lots of alcohol. Actually, the reason why we're making a wine. So, in essence, if you're over-consuming a lot of fiber, your gut, the colon becomes a small beer-making factory. And that leads to a lot of problems, and colon cancer is being one of them. And then I thought, okay, fine. So probably people who are consuming a lot of fibers, they are subjected to tremendous risks of colon cancer, and maybe colonoscopy is a very helpful procedure. Maybe they should do it as often as possible. And so I went on to it on that procedure, and suddenly I come to the site of the National Cancer Institute, and it says specifically on the site, it is not yet known, and I'm quoting from the site, it is not yet known for certain whether colonoscopy can help reduce the number of deaths from colorectal cancer. So that was back in 2007. They specifically said, listen, colonoscopy is useless. It doesn't do anything. And when I want to investigate this even further, and I was absolutely stunned by the number of side effects related to colonoscopy. I mean, intestinal flora disruption, disruption of stools that leads to chronic constipation, post-interventional complications, increased risk of deferred strokes, heart attacks, and pulmonary embolism, which can lead to near-instant death. Multiple infections, and this is even before touching the subject of complications such as perforation or whatever. Then, apparently, not apparently, but actually, an improvement by research, a lot of tumors are being missed. Actually, 95% of the polyps which are discovered during colonoscopy, they are benign. They will never become a colon cancer. And the rate of complications from colonoscopy is huge. It's the most riskiest testing procedure. It's 10 times riskier than a prostate biopsy, or 10 times riskier than biopsy of breast tissue or whatever other procedures it investigates, because it's essentially an invasive surgical procedure. People are provided with anesthesia, and you're an anesthesiologist, you know the outcomes of that, and very often physicians who do colonoscopy outside of hospital settings, it's not actually a board-certified anesthesiologist who presides over this procedure, but a nurse. Training there is substandard. They always rush because it's a conveyor line, and actually doesn't do anything. A lot of research came in the last couple of years which indicated whether you do colonoscopy or you don't, mortality from colon cancer remains the same. Also, a dominant cause of colorectal cancer is genetic, and people who actually will die from colon cancer related to genetic causes, and actually that was a cause of death of Miss Corrick, who was the actual promoter of that issue. Her husband passed away at 45, and the first colonoscopy is recommended at 50, so it's past the age when dominant mortality will happen. And actually, the age of actual diagnosis, the predominant date of when most people will die from colon cancer, will discover colon cancer, is 72, but we start at 50. And now another jeopardy came about is virtual colonoscopy, because we have tremendous amount of radiology centers, and a lot of the CT scanners are empty, and so people are recommended virtual colonoscopy because apparently it's an easier procedure. You don't have to go through colon prep. It's non-invasive, but it's actually useless. And not only useless, it also subjects you to the same dose of radiation as the people in Hiroshima or Nagasaki who were on the outskirts, who were in the suburbs of those towns. And that procedure alone, one single virtual colonoscopy, that increases your risk of a fatal cancer by 20%. So the risk of any cancer from virtual colonoscopy is the same it's much higher than the risk of actually dying from colon cancer, because it's only 1 in 50 people are actually at risk. But if you do a virtual colonoscopy, your risk becomes 1 in 20. So that was a very, very sad fact. And what I did is I wrote a private letter to Ms. Corrick, saying to her, listen, stop your overzealous promotion of colonoscopies. They're useless. And it has nothing to do with my opinion. It is written all over the place. Journal of American Medical Association, the New England Journal of Medicine, The Lancet, and everywhere you go, the National Cancer Institute. And I sent to her that letter with all the links, and I wrote a report entitled "Colonoscopy: Is It Worth the Risk?" I put it on my site, and she didn't even respond. Nothing happened. I said, well, maybe she didn't get my letter, which is obviously impossible. The compliance on this major television studios is legal compliance is very high, so they have a course of people reading this letter. I went on and I made a posting on her blog. No response, no reaction. 6 months later, when there was no reaction, I did the same report on video, put it on YouTube, and again, no reaction. And then, in an instance of tremendous naivete, I wrote a little letter to our president, who at that moment became elected in 2009, not elected already, sworn in, and he was requesting, at the time, please, if you have some civic issue which can reduce medical expenses, which can improve the life.
I remember when he put that out. He said, if you have any hints you want to pass on to me. So you took him up on that, and you sent Obama a letter, huh?
No reaction whatsoever.
No reaction there either.
No reaction, and obviously it wasn't for him to read, it was for his staff to read. And his staff completely ignored it, didn't warn him, didn't warn the First Lady. And a year later, Mr. Obama himself was subjected to virtual colonoscopy. And considering the fact that he's an African American and his maternal history of cancer and his stress level and the fact he's a smoker, so you can imagine what that little procedure did to his health. And that's what it is actually when you have an ignorant staff and actually when you don't follow up on your own promises. But let's not get into the politics. So that's my little take on colonoscopies, and I welcome everybody to come to my website. It's, again, gutsense.org. Under the menu GutSense, there is an article there, really, colonoscopies, it's worth the risk. And you can read all those letters and all the subjects and watch 5 videos. And also, I didn't want to be like, threatening people without actually giving them the reasons, telling them what to do. So I also have about 6 pages dedicated specifically to what you can do to prevent colorectal cancer, and I also outline all the risk factors related to colorectal cancer when people actually do have to do colonoscopy. And also, I want to say this, please, especially to physicians who may be listening to us, please do not confuse screening colonoscopies of healthy people who have a very, very low risk of actually being affected by colorectal cancer with diagnostic colonoscopies with people who are presenting themselves to physicians with a colorectal bleeding or with some kind of a very severe pain and this and that. So the 2 different procedures. We are specifically talking about healthy people at age 50, 55, 60, 65 going to a procedure which has more side effects and the risk of major injury or death higher than the risk of death specifically from colorectal cancer. By my estimates, about 70,000 people a year are damaged or injured or actually are dying from that procedure, and the total overall mortality in the United States each year from colorectal cancer is only 30,000.
Now, you just gave, I've jotted so many things down as you were speaking. So loud and clear, I hear you saying that it's the screening colonoscopy, the one that seemingly, because we have screens for everything, like I put this in the same category as mammograms, which we don't have to get into right now, but I'm a big, I really criticize the use of mammography for some of the very reasons that you're thinking that the colonoscopy shouldn't be used. But a screening colonoscopy means you don't have any symptoms, you don't have anything, yet people who are gastroenterologists are trying to convince you that you should just for the heck of it go have a colonoscopy, well, because of your age. That's the one you're reeling up against, is it not?
Yes, absolutely. And, and this is not just my opinion. There was a very prominent book written by Dr. Gilbert Welch, Should I Be Tested for Cancer? And he analyzed there all the data related to colorectal screenings, to mammograms, to PSA checks, and other common tests. And he specifically said you shouldn't do those procedures because they subject you to a much higher risk of death from all the side effects related to those procedures. And that's even before talking about stress, about money that you'll be spending, about time you will spend away from work, and so forth and so on. And all of those procedures, apparently, at least my judgment is those procedures increase your risk of specific cancers they test you from, by even larger factors than the underlying cancer itself.
Well, I could say this, because I do know a bit about mammography. If we're looking at yield, where somebody who doesn't have a symptom at all steps up and gets a mammogram, how many detections of a malignancy are encountered through that kind of screening process? And in the case of mammography, there is only 1 malignancy found for every 70,000 mammograms. Now that's a statistic that I know. Okay,
that's falling.
Which is a completely wild, number. I mean, 1 in 70,000. Now, in the case of screening colonoscopies, with serious pathologies found, do you happen to have any statistics about what kind of yield there comes with the colonoscopy, or is that the wrong kind of way to approach this?
Well, it's even the wrong kind of way to approach it because we don't have as massive screening as with mammography. It's not as frequent. It's only once every 10 years, not every year.
Mm-hmm.
And furthermore, we started this pervasive promotion of colonoscopies about a decade ago in 2000. And since then, despite millions of screenings performed between 2000 and today, the annual incidence of colorectal cancer increased by about 30,000 cases. And in my book, this increased, and people say, well, it's probably related because we're discovering now those colon cancers. No, I don't believe it is happening because we're discovering those colon cancers, because again, the dominant number of people with genetic colon cancers, they will be dead even before the first procedure is due. It is probably related to the fact that we are subjecting people to those invasive procedures, to virtual colonoscopies, and also for a very abusive use of CT scanning in general, abdominal CT scanning for all other purposes.
Okay, now, looking at colonoscopy, what is the actual, because I don't know, it's amazing, what is the actual recommendation for screening colonoscopy? Is it one every, in a decade, once every 10 years? Is that the way it is?
Once every 10 years for a regular colonoscopy starting at age 50, and actually physicians who are involved in gerontology, they say by age 75 or even 70, you should never do it because even if you develop colorectal cancer, it takes a very long time to develop. Most likely you'll be dead before that cancer will affect you. Secondly, now American Association of Radiologists and radiologists are pushing very hard the implementation of virtual colonoscopy, and I read a lot of suggestions that people should do virtual colonoscopy every 5 years, starting at the age of 50, or at least in between regular colonoscopies. And so, if you will do one at 55, and one at 65, and one at 75, those three procedures alone will bring your level of being affected by all other cancers by incredible amount of it's not an arithmetical increase every time, but it's more geometric, so it's very hard to say what level specifically will be, but it's very, very harmful for people.
Okay, so screening ones are one every 10 years, and then I believe if you have a history of colon cancer in the family, that changes the numbers, and isn't it could become an annual thing at that point? Or when?
Oh no, annual is impossible because it's a very complicated, it's a very involved procedure. It's not like a mammogram or PSA test. I mean, it's actually a surgical procedure. It takes a lot of effort and a lot of time and a very complicated prep. So no, it probably will be maintained at this level of once every 10 years. And in fact, I mean, for people who are in a high-risk group, I think it's a very worthwhile procedure. But people who are in a low-risk group, it doesn't do anything. You know, the risk of colorectal cancer is essentially for a person in a high-risk group for colorectal cancer, it is 12 times more likely that the person will die from a heart disease, 10 times more likely from any other cancer, 6 times more likely from a medical error, and 3 times from stroke, and twice as likely to die from an accident. So the risk of actual death from colorectal cancer is tremendously overblown. And besides, even if you are paranoid, all you need to do is fecal-occult blood test, and now those tests are very sophisticated. They are not simply just the strips of paper that you show in the toilet, but if you do it at a physician office, they can also do a very specific markers, biological markers for colorectal cancer. Even a very basic blood test today can establish some antibodies to cancer in your blood, and so then you can follow up with a specific test. So there are so many ways people can do before subjecting yourself to the test. Even I read somewhere that dogs, specially trained dogs, by smelling your stool can determine colorectal cancer long before a virtual colonoscopy or regular colonoscopy.
Bring in the dogs. Bring in Brutus. Oh my goodness gracious! All right, let's take that.
My dogs are good.
Let me ask you this. Well, let me just say this. I've been involved personally with hundreds, as the anesthesiologist, hundreds of colonoscopies. And one of the things that I'm going to guess that really is the biggest concern, most serious concern during a colonoscopy is the chance of perforation. Because unbeknownst to the conventional medical community, or certainly the lay public, is that they have to use the injection of air into the colon, in order to allow the scope itself to meander through the various turns and dips and ups and downs to the colon. And by putting that air into the colon, they have perfed it. Now, what that just means is they've blown a hole in it, okay? And I'm going to guess that the likelihood of this happening would increase if you have diverticuli, would happen to be even greater opportunity. But this turns out to be an emergency surgery that's required if you perf somebody during a colonoscopy. Do you happen to know, because I don't think I know offhand, what the frequency of perforation is during colonoscopy?
About 0.1%, so 1 for every 1,000 that we know officially.
Well, that's at least pretty a minor number, but of course if you're the one that it involves, the number becomes a real one, but still, in my opinion, it was the biggest potential, at least what we were concerned about when we were involved with it. I will say, when you mentioned that anesthesia was required, you don't really have to have a general anesthetic, but you get sedated to the point where you have no awareness, and I think that's at least humane. And you're right that the GI labs now exist in parts of the hospital. When colonoscopies were first done, they were done literally in the operating room suites, right there where the anesthesiologist and anesthesia personnel was available. But as the issue of paying for anesthesia services became a factor, this got moved into the, and I'll use the term quite loosely, the bowels of a hospital, somewhere down in the basement, some lab down in a corner near where the janitor hangs out, so far away from anesthesia personnel, and a nurse was trained to administer the anesthetic, and that, I think, is an issue that the public is unaware of in terms of, I think, additional risk. I think that is additional risk. What do you think?
It is a tremendous risk, yes.
Okay.
And especially for older people. I mean, if you're 50 years old, it's not a big deal, but if you're 60, 65, that's a very, very high degree of risk.
All right, we should probably talk about when it would be that the colonoscopy would be advised. I'm going to throw one up there that I think probably would, in my mind, necessitate colonoscopy, and that would be in the case of a GI bleed, okay, where I think the normal course of action, the way this happens usually in the world of medicine, is a person gets a blood test and finds out that they're either frankly anemic or bordering on anemia, and in their age group, that would be extremely rare. It shouldn't be anemic at all, and if you have these low hemoglobin hematocrit numbers, these would be in favor of going and looking for a bleed somewhere. It's going to be assumed, or at least it should be assumed, that if we have low H&H, hemoglobin hematocrits, bordering or frankly anemic in terms of its range, that a colonoscopy is probably the very first thing that should be done. Now, what do you think about that?
Well, yes, you're absolutely correct. That's a clinical indication that you have to find out the source of bleeding, and most likely, if your stools are not particularly dark, it may be a bleeding within your colon rather than the stomach. Very, very slow bleeding. It takes years and years to develop. But second and most important, most highest risk group are people with ulcerative colitis. They have a risk of colorectal cancer about 30 times, 3,200% higher than general population. Going down, people with what is called inflammatory bowel disease, which is a condition that precedes ulcerative colitis and Crohn's disease. Going further down are people with irritable bowel syndrome, especially irritable bowel syndrome, which is diarrhea predominant, because these people are borderline IBD, meaning inflammatory bowel disease. And further down, if you have a long time history of constipation and hemorrhoidal disease and diverticular disease, it means that your colon is not functioning in its optimal fashion, so you may be at a little bit higher risk than those groups that we just mentioned. Obviously, if you see any signs of blood in your stools, which are not easy to detect, if you already have an obvious bleeding, you are in a serious problem. But again, it's not always a colorectal cancer. It can be a diverticular disease. It can be a fissure. It can be bleeding hemorrhoids. So, but you still have to go on and see the physician immediately.
Let me bring you something up that I find that for some reason it just doesn't happen anymore. In my medical training and part of a normal workup on any patient, we used to do standard on every single patient what was either called hemocult, sometimes called a guaiac test, literally where we took a fecal smear and there was a special little cardboard perforated thing that we put the smear on and put a developing fluid on, and instantaneously we could learn whether there was not macroscopic but microscopic amounts of blood. And this was done on every single patient that I ever had to do a workup on. I check with patients now. They tell me no such test is being done, and that what's happening in the medical community is they're suggesting, first off, to do the colonoscopy when concerns of bleeding come up. They don't even check the stool to make certain that there would be the presence or absence of any blood. And I'm just running by you, if you're aware of that test, and if I'm right, at least in what I'm hearing from my patients is, this is a test that's not being done anymore when it was so convenient to use and there wasn't any risk to it at all. Now it seems like it's a test that's come and gone, very difficult to find. Am I right about that?
You're absolutely correct about that, and there are reasons why it is happening. Number one, young physicians, when a person presents themselves, they're not really up to sticking their finger into your anal cavity to extract it a little bit. Well, you don't put the finger in, you just put, what is it?
No, it's a digital extraction of
sometimes digital, sometimes they have, And so it's not a very pleasant procedure, neither for the patient nor for the physician. Number two, it's a time-consuming procedure. So it is not economically feasible. If you do present yourself to a GI doctor today, to a board-certified gastroenterologist, he will definitely do the test. A lot of colonoscopists, actually, before doing the colonoscopy itself, they will also do the test. So they will be more aware, they will look more carefully for possible complications. But you know what's interesting? You can go today to any drugstore and buy those strips in a drugstore for about $15 and just drop them in a toilet bowl, and it will show you exact same thing. But yes, you're absolutely correct. Those tests were always done. They should have been done, and that actually, this whole conversation today was precipitated by an article released by the Journal of National Cancer Institute that just published not long ago on November 9th, and that article was entitled "Less is More: Not Going the Distance and Why." And it specifically said that colorectal screening by means of virtual or regular colonoscopy is a very high-risk medical procedure, and they, I say in quote, less colonoscopy can mean more well-being for all of us. And that's not Konstantin Monastyrsky, that's the National Institute of Cancer. Those people are specifically trained to analyze statistical data, specifically trained to analyze clinical outcomes, specifically trained to make those conclusions and publish them to all the physicians. So if the National Cancer Institute says less colonoscopy can mean more well-being for all of us, it's very, very hard to question that logic, unless obviously you build up your own standalone colorectal cancer screening clinic and you're making $8-10 million a year, then obviously you say, no, those people are wrong, come and get tested.
Now, you mentioned when you first started our discussion today, you mentioned Katie Couric, and you know, of course, her husband Jay, Connie, I forget his name exactly, but her husband Jay did succumb. He died of colon cancer, and she sort of picked this up as her pet project. So much, in fact, if I'm right about this, and I think I am, that she actually consented to have her own colonoscopy shown on television. Am I right about that?
Yes, that is correct. She did it twice. Once a regular colonoscopy and once a virtual colonoscopy. And she started this as a very benevolent project. I think she was well motivated by the death of her husband. Again, it was a very deceptive campaign to begin with because her husband had a genetic colorectal cancer at age 45. And so colonoscopies to people in his situation simply wouldn't help because, again, the first colonoscopy that healthy people are recommended is at age 50. And she went on to actually build a tremendous career out of that. You know, people felt a lot of affinity for her. They were saying, well, she's doing a very important civic work, but it wasn't really that civic. She was at the time employed by NBC, and NBC was wholly owned subsidiary of GA, General Electric, and General Electric made a quarter of their money from selling medical imaging equipment.
Sure.
And CT scanners. And so they went on to promote CT colonoscopy, and obviously she was quite vested into GE. She was a shareholder. She was a prominent spokesperson, and it led to this very, very intense promotion of virtual colonoscopy. So it started as a benevolent project, but I don't think it was really that benevolent. And you know the outcomes when she left NBC, where she was making several $1 million. She was offered $15 million by CBS, and then she got a counter offer from NBC for $20 million annual salary. So she made quite well for herself on the football racket.
Yeah, let's just give her motives all the greatest in terms of intention at this initiation. And at least as it stands right now, I don't know of a reality show that's coming up about the X Factor for colonoscopy. There's no TV show that you know of that's taken the celebrity colonoscopy to another level. Correct?
I don't think.
I don't think so.
They do know, especially since my report and since all other writings, and also a lot of data came out about how badly those colonoscopies are performing. Also, I want to let everybody know that the whole purpose of a screening colonoscopy is to find out precancerous polyps. But actually, most colorectal cancers are not from detectable polyps, but from so-called flat lesions. So, and a lot of them are being missed, or actually they're impossible to discover.
All right. One word, I don't know so much if our listeners can appreciate what's meant by virtual colonoscopy, because this seems to be where everything is going in terms of the future. Could you describe this ingestion of, I think it's a camera that you end up swallowing, and this thing checks you out from mouth to anus? Am I right about that? Describe the virtual colonoscopy for our listeners.
Well, the traditional virtual colonoscopy is performed either with computer tomography. The computer tomography is a very large tube, X-ray machine. The person slides through the machine, and while the person is being slid through the machine, it takes about 500 to 600 images of your abdominal cavity, X-ray images, and it subjects you to a level of radiation which is comparable to the radiation that people got when they were in suburbia of Hiroshima or Nagasaki when the bombs went off. And it's a very, very high dose of radiation, about 10 millisieverts, and it has very negative consequences. Your risk of getting any fatal cancer from the procedure alone is about 1 in 5. Then, obviously, the safer approach would be MRI, but MRI equipment is much more expensive. It's about 5 to 10 times more expensive than colonoscopy and CT scanners, so it's not as omnipresent. And also, for all the people who have, let's say, pacemaker or some other kind of, false teeth or dental work with metal, you cannot put them through the scanner because it has a very high magnetic field. So it's not done as often. But anyway, if you're being offered that and you have an option of MRI versus CT scan, you should never ever do CT scan, because MRI is just as high quality and it has no risk associated with actual radiology. Now they have also a new mechanism. People swallow the capsule, and that capsule transits through the entire alimentary canal, meaning from mouth to anus, and then you wear a holster, and then about 24 to 48 hours later it will go to a toilet, and you return the holster back to your GI doctor, and he will look at the video, or she will look at the video, and will see if you do have any kind of polyps or lesions. But the other problem with all the virtual colonoscopies is that even if the procedure is done and the physician or radiologist will see something wrong, then they will have to do a regular colonoscopy.
Then they're going to be scheduled for the regular colonoscopy. Correct.
Exactly. So it's completely pointless, but it does make a very good amount of money reimbursable by insurance for those people who administer those procedures.
Yeah, I was familiar with the swallowing of the camera. I didn't realize they actually had a CT, the full length of the GI tract, 500 different X-rays taken. This, with the lights off, you would blow when you're done with that. Is just a tremendous amount of radiation. Anyone that would even do that, I question their medical integrity to do such a procedure. It's just CT scans of that magnitude should be outlawed. It's like doing a CT scan to determine if you have any malignancy anywhere where you sweep somebody from nose to toes. It just doesn't. The risks are so great in terms of X-ray exposure that even if they detected a cancer, if they didn't detect a cancer, they're going to provoke one probably within the week. Unbelievable.
Absolutely. Full body CT scan is about almost 20 to 40 millisieverts, and they do actually a double pass. One pass regular and one pass with a contrast solution in the blood, iodine in the blood. And so they can expose a healthy person to 40 millisieverts, which is 4 times of what people would get in Hiroshima. And I actually had a friend of mine. He was a very wealthy man, and he did all those full body scans every year, and he passed recently. Not long ago, he passed from a brain cancer.
Wonder if there was any relationship there, huh?
Without any doubt.
Without a
healthy 55-year-old man living in great conditions, very athletic, relatively healthy, and suddenly, bomb, brain cancer. He's dead within a year.
I tell you, we're coming right at the end now. We're going to have bongos coming on upon us in a moment, and you're guest enough here in terms of frequency. You know what that means. So pull it together for us, Konstantin, and get us ready for our next visit for next Monday. How do you want to close off this discussion today?
Well, again, let's summarize the harms or unnecessity of that procedure. An estimated 95% of all the polyps are benign. Not all colorectal cancers are preceded by detectable polyps. The procedure itself, especially when it is done with, the procedure itself may increase your cancer risk, especially when polyps are being removed, because the removal procedure releases cancerous cells into bloodstream and columns lumen. It is very unreliable. Even the most thorough endoscopist may miss up to 30% of detectable polyps, and the less rigorous will miss up to 60% of even actual cancer tumors. It is unnecessary. The average age of colorectal cancer diagnosis is 72, so commencing invasive screening and polypectomies in asymptomatic healthy people at age 50 is just as absurd as taking contraceptives after menopause. It is you carry a very high risk of internal bleeding, especially if you take blood thinners or aspirin. Polypectomy profoundly increases patients' risk of death from hard-to-detect internal bleedings, which may lead to ischemic stroke, myocardial ischemia, cardiac arrest, or sudden cardiac death.
All right, tell you what, we're going to leave it there. We're going to leave it there. We're going to bong it in the background. We'll have you close this off next Monday. Konstantin, I'll see you next Monday, all right?
Thank you very much, Dr. Courtney.
Thank you.
I wish everybody a great day in Pennsylvania.
Okay, there you have it, folks. Konstantin will be back next Monday. See you then. See you on Wednesday. Bye now.
AM Impact on Your Health is sponsored by Dennis J. Courtney, MD, Director of the Courtney Medical Group, located at 3075 Washington Road in McMurray, Pennsylvania. For more information or to make an appointment, call 724-942-3002. That's 724-942-3002. For